Hey everybody, Dr. Jones here. Here's a brief lecture on schizophrenia spectrum disorders. As always, you have a lot more information in your module. You have over 100 slides. I'm just going to hit really a quick introduction to schizophrenia and the spectrum of schizophrenia. It's important that remember that it is a spectrum and has evolved over the years. So let's talk about that. I want you to understand the criteria for schizophrenia. Um, it's the major psychotic disorder, and later on in the PowerPoint on your own time, I want you to learn about the neurotransmitters that are there, and I want you to look at good and poor prognostic factors. This is a very, very serious illness, of course, but it's not a death sentence. I mean, I worked one time with a psychiatrist who had schizophrenia, and it was amazing. He was in the hospital where I worked. His meds got out of whack, and he knew enough to understand that he needed to get stabilized. And he came into the hospital, got on some different meds, and went back to his job as a psychiatrist. So I've never forgotten that. I think that's amazing. So people can live and work and have families and things with schizophrenia, but it is a very serious thing. We're going to look at some of the psychotic symptoms, and I want you to be able to kind of reasonably diagnose someone. So what is it? What is schizophrenia? It comes from two Greek words, which is schizo, meaning split, and phrena, which means mind. So the split then is when someone's thoughts are divorced from reality. So if someone is seeing things crawling up the wall where there are no things crawling up the wall, that's an example of that. Um, so the definition is people with schizophrenia have distorted thinking, they have distorted perceptions, they have distorted language. Um, and often they hear voices, they are delusional. They think that they're the king of the world, or they think that the FBI is tapping their phone or something like that. Um, as I mentioned, it's a pretty disabling kind of disorder. They're 2 to 2.5 times more likely to die earlier. And you often see problems with physical illness, infectious diseases. It is difficult for someone with severe schizophrenia to be employed. Thankfully, there are some kind of sheltered places and also some supportive places that they can work. But often, honestly, they can be homeless if they don't have the right kind of care. So it's a pretty serious thing. There's lots of stigma and discrimination around it. It is treatable, though, and so it can be treated with medicines. We have some wonderful medicines for it now, and also with psychosocial support. So let's look at delusions for a second. Delusions are kind of these fixed beliefs that are not changed in light of the evidence. So often they are themes of being persecuted. They're often religious. They're often sexual, erotomanic, nihilistic. And so they are often bizarre, and sometimes their thoughts are inserted into someone's mind, and those are bizarre kinds of things. There is a video in your module that I very much want you to watch, and that is of someone, um, that is experiencing schizophrenia, and just something simple like brushing their teeth is very difficult for them because they feel like their toothpaste is poisoned, and all day long they hear these words in their head, don't drink that glass of water, it's poisoned, or what is that knock at the door, or don't open that mail. Very paranoid kinds of flavors to their delusions. A hallucination is occurs when the person hears or sees something like they would for it to be just a normal perception, and it's not in their control. So, smelling smoke where there is no smoke, feeling a snake or wrapped around your arm where there is no snake, seeing things crawl up the wall. Disorganized thinking is another area here. So, derailment is something that I'll see if I can demonstrate derailment for you. So it would be somebody saying like, um, yes, doctor, my mother sent me here to see you, and my orange toaster caught fire on the roller coaster when I went to the park. You know, it's just kind of this starts out okay, but then it just kind of derails. And that's also an example of kind of loose association. So orange toaster doesn't really, make make sense very much in terms of the context of just describing a toaster. So disorganized thinking, I mentioned grossly motor behavior. Go on YouTube and look up the term catatonia, and it's pretty amazing. Uh, I've only seen one person who was experiencing catatonia, and it was very sad. The person is almost frozen they're just frozen. Their facial features, everything are just frozen. So go in, look at that as well. Um, it's really important that we distinguish between negative symptoms and positive symptoms, and it's not what you think. Positive is not good. So negative symptoms are decreased emotional expressions. So, just the everyday person, like you're watching me here, you're watching my face. I have facial expressions. I'm smiling sometimes. Sometimes I'm, being more intense. Someone with negative symptoms, they may just have a blank stare. They may look very depressed, actually. Um, and they also may have a decrease in motivation, self-initiated activities. So they look kind of depressed, and that's where we have to make sure that we understand that they're not. Not being social, anhedonia is just kind of a lighter form of depression. So again, positive symptoms, negative symptoms, and then there's secondary symptoms. So positive symptoms are things that are not supposed to be there that are there. So hallucinations, delusions, thought things. Negative symptoms are things that are supposed to be there but are not there. So emotion, poverty of speech, abolition, those kinds of things. And then the secondary symptoms are things like breakdown of relationships, loss of employment, depression. So it's very important that you distinguish between positive and negative symptoms. Negative symptoms are much less dramatic, but they tend to last longer than positive symptoms. So if you have somebody who is hallucinating, if you get them on some decent medication pretty quickly, those hallucinations typically go away or are kind of diminished. Those negative symptoms tend to stay longer. So we want to look when we're evaluating someone, we want to look at positive and negative symptoms. So with negative symptoms, they tend to start before the positive ones. Um, Sometimes they start years before diagnosis. So if you see someone, and they call this the premodal, I think I have that right, premodal stage of schizophrenia, maybe someone in their teens, early 20s, they are just kind of strange acting. They may have some weird beliefs, something like that. Um, Pretty amotivated. Those things are more common. They start earlier. Um, Positive symptoms, they can be affected by cultural differences and they tend to have greater weight. So, and it's really hard to measure objectively. I mean, sometimes what I tell students is, sometimes people are just they just have weird beliefs. That doesn't mean that they have schizophrenia. They just have odd or unusual beliefs or they're eccentric in some way. That's not schizophrenia. So with positive symptoms, you're seeing those active hallucinations, you're seeing active psychosis. I think I mispronounced before. The prodromal stage phase is what I was talking about. Prodromal stage, the phase there. Um, so that person becomes withdrawn, they lose interest in work or school. And then the active phase is one where the symptoms begin to occur and they lengthen. And then there's the residual phase, which symptoms kind of subside when treatment is given. So the illness usually occurs in these three phases. So the rule of thirds is something that you should know. And again, this is just a general statement. About a third of people with schizophrenia recover more or less completely. So that's really important to remember. If you're ever working with a family, again, this is not a death sentence. The person's not going to be homeless. They're not going to be locked up in the psych hospital their whole life. About a third of them will recover completely on medication. We have some wonderful medications now. About a third of them will have episodes like the psychiatrist that I mentioned. He knew enough to know that he needed to come in and get his medication tweaked. And so he checked himself into the hospital and got on the right path and was back to work. And then about a third have kind of this chronic decline that we see. So about 60% of patients maintain a relatively normal life with treatment, and that's very important. If there's no treatment, it's pretty awful. Prognosis is better in the non-industrialized societies. This is the video that I was telling you about. I hope that you will take some time to watch that. Um, so I'll kind of finish up here. And then I will invite you to go on through the PowerPoint and look at these different types of schizophrenia spectrum disorders. So, of course, schizophrenia we talked about, schizophreniform disorder, and schizoaffective disorder. These are kind of difficult to understand. And so there's an element of psychosis in there, maybe withdrawal. With schizoaffective disorder, though, there's also a pretty significant mood issue. And so, again, this is very important that you um, find out a good history about people, that you understand, is this bipolar disorder? Is this depression? Is this schizoaffective disorder? Is it just straight up schizophrenia? Try to get a really good history on people. Ask family members, ask collateral people that can help you with that. Delusional disorder, again, are just kind of these fixed delusions that people have. There are several types of them. Again, they can be paranoid, they can be kind of sexual. They're often very religious. So I had a client one time who was very religious. He was a devout Christian and went to church, but when the preacher was preaching, um, he would have delusional thinking about the message and he would kind of take it too far and it would scare him. And so we had to work on, medicine was the primary mode of treatment for him, but we had to work on that. Brief psychotic disorder is just what it says. The person may have a very brief thing. With schizophrenia, you're going to see weeks and months of psychotic processes going on. Other psychotic disorders, just a catch-all. And then secondary psychotic disorders are